Hi, good morning, everyone. Thanks very much. Thanks, MQ. Thanks, Anne, for inviting me today. It's a pleasure. So, quick questions before I launch into it. Just to understand who you are, how many of you come from a clinical background? How many of you got clinics, clinical ideas, thoughts, concerns, it running through your veins? How many of you come from what we'd say an informatics background? So, not necessarily academic, PhD, etc., but actually handle health service data or routinely collected data. So that's really helpful to know. And how many of you are, dyed-in-the-wool academics? Yeah, okay, lovely. Okay, great. Okay, so thanks very much. So I'm a late developer. I'm a late academic developer. I'm a child and adolescent psychiatrist. I became a consultant and then became deeply preoccupied about why my profession wasn't doing the things that it should have been doing, which is going out and treating and looking after as many young people as we could and get them out the door in good mental health for the rest of their career or life. And so that because of those sorts of concerns, I'm really driven by clinical problems and then trying to find applications that can then fix them, whether they be digital or whether they be, improving resourcing or whatever. It could be human. One of the challenges that we have at the moment is the fact that we don't have enough human capital. There is a real scarcity in provision of mental health resources. This doesn't pertinent just to children, but it's pertinent to all mental health to deliver the care that we need for the population. We just don't have enough hands to the pump to really deliver the care that the population deserve. And over the last few years, it's become increasingly stark. And I think we can now feel fairly convinced that the prevalence of psychiatric conditions, especially in young women, is gone through the roof. And the need that's delivering that people that are recognizing they've got an issue and actually coming to our services has increased exponentially. So just on the line graph on the right hand side, on the y-axis, those are thousands. So you've got when we first sort of April 2019, and we were already struggling. So people were on waiting lists for a year or so before they really got properly seen and treated. So 250,000, and now that's incremented up to 420,000 and growing. And we still have occupancy rates in terms of staff occupancy issues of around 70 to 80%. So it means that 20% of our workforce that we have funding for are still not in place. So we have a time of incredible scarcity, but really high demand. And that is fertile ground, I think, for business cases to say that we need to innovate. We really need to find alternative approaches to actually delivering the care that we want to deliver. So the premise of this talk really is to speak to the clinicians and say, my God, you're really needed in terms of being able to set the problems, being able to articulate the data that's available or the information or the sample or the people that can help articulate those problems, to define them. And those problems are to then be supported by data scientists, either in terms of thinking about how you can better understand and track those problems over time, or how you can start to fix them, how you can start to design interventions that target populations that need. So for the data scientists, it's really, really important to have your clinical colleagues with you in order to come with a sort of enthusiastic optimism towards the data that you're looking at. And I'll talk to that throughout the rest of the talk, is that you can't always trust the data. You've got to validate it, and you need your clinical colleagues, or you need your primary sources of data to be able to describe the strengths and the pitfalls of that data. But the main strategy, and this was the business case that I put to the trust in order to get funding to have me and other staff members, which I'll talk to, was basically we really need innovative approaches to develop preventative strategies. We've got to dampen this prevalence in the population, and we've never done that as a mental health service. We've never really altered population prevalence of mental disorders. We need to adapt the existing treatments to make them more widely accessible to those that can't actually advocate for themselves or get the support they need to get them through the door and engaging with secondary services. And also within CAMHS, we need to find methods of enhancing the efficiency. And can we do our job better? Can we make it more efficient? Can we do less tiresome tasks in order to speed us along? in terms of delivering treatment. So briefly, this is the landscape that we're up against, is that we know that there are incredible problems. They're great things, but there are generally incredible problems associated with the delivery of CAMS services for children and adolescents. We know that we don't have a coherent approach to primary and secondary prevention. I think Anne can speak more on that, but it is generally a real issue. We provide services unfairly, so we don't go out and look at the most vulnerable or those in marginalized communities and actually say, look, here's some care for you. We've got limited health intelligence, so we're not very dynamic at being able to understand where the needs are, how they're discrepant in the population, and where we would best be put resources in order to tackle a population need that might be quite specific in a certain community. We have agonizingly long waiting times, we've got unclear treatment paths, and we're not integrated with the third sector or commercial services very well. So that's the kind of service problems that we think that could be supported by digital work. And then the problems with the digital sort of environment is that we haven't really got any clear framework. I don't know if any of the clinicians have a care pathway in mental health which really integrates any digital interventions or treatments or analytics. I don't think that really exists. So we don't have clear ways of being able, we know how we can introduce psychological therapies, we know roughly how we can introduce medications, we don't know how to introduce digital applications or intelligence. We don't really have much of a framework for evaluating the harms and benefits of any digital therapies that we put forward. When products have been trialed, and I don't know if you've done this, but we do occasionally systematic reviews of the literature, and we find that the therapies that seem to be quite compelling, that be working in terms of providing unsupported cognitive behavioral therapy for adolescents, we can't actually find them. They just don't exist. They're buried in servers in university systems, or they're sort of hidden somewhere, or they've been decommissioned. So there's no effective products aren't sustained. We don't really yet have a process of continuous improvement in terms of agile software processes for sustaining, iterating, and changing products. And also we have limited capacity in the workforce. So I'm really pleased to be able to talk to people that's going to drive up capacity. So the way that we organized ourselves in the CAMS Digital Lab, so it was me saying, look, God, there's a problem. We need to basically sort this, that we need to look at least the digital objectives or the digital mechanisms for improving care. People say, okay, well, here's some money. Well, how are you going to organize how you're going to deliver that care? So we sort of split ourselves up into 4 themes. One is to take use of our existing electronic healthcare record, our population data as well. There is lots of quite incredibly exquisite, detailed, routinely collected data sets, whether it be taken up by schools, whether they be taken up by other secondary acute care providers, primary care, our service. And I know you've got Rob Stewart coming, who's probably going to talk more about unlocking the electronic healthcare record and the free text and all of that within our existing routine care systems. There's sumptuous amounts of data that we can start to glean a little bit more knowledge from. We do need to find better mechanisms for then knowing what types of treatment we want to deliver. So we need a sort of enhanced and therapeutics pathway, and I'll give you some examples. We do need to work out how we can bring in innovations from data science, the speech, vision, haptic, VR. How do we move those technologies into our clinical pathways? And also we need some way of being able to build our capacity, understand these tools and interventions to be able to embed them in clinical practice. So we need an continuous education, training and outreach program. Sorry, and I should have said bookended by a commercial arm. So some way of being able to keep these products sustained, and equally make sure that we have a very powerful voice of patients and carers that are embedded throughout the sort of co-design pipeline in order to produce these products and also iterate and sustain them within clinical services. So I'm not going to spend too long on this, but people talk a lot about the technology. What you really, really need is make sure that you've got decent governance, because you can come with some beautiful ideas, some exquisite products, but if you don't have some method of being able to make sure that they're working right, that they're fit for purpose, and that you've got the capacity to sustain them through funding or through human resources, they're going to die. And we've had lots of wonderful prototypes developed that have never seen the light of day in clinical services because they haven't had the governance wrapping. So I'm just going to pop that slide up just really to illustrate what's needed. It needs to be a tethering between actually the service delivery and the service assessment right at a trust executive level, NHS level, all the way then down to project management and work stream governance for different projects. And the projects I'm going to speak to, I'm going to try and sort of work through these different buckets to give you examples of the products that we're producing within the lab. So just to start with, so given an example of basically a kind of clinical and population analytics product, on the left-hand side is that we've got examples or tracks of routine data. Most trusts would have this data somewhere tucked away in a business intelligence system, or they might even have a kind of research application that's able to draw this information out that just tells you week on week how many people are presenting to accident emergency services. And it's a good barometer for the sort of crisis, unplanned emergency care that's required by your population. The trouble is that it doesn't really tell you. So you can look at those numbers, but you don't really know who's turning up because you've got very scarce information collected in A&E, and you don't really know in terms of the population where they're coming from. So whether it be, is it Summit? So how are you then going to focus your resources in terms of thinking about preventing upticks in A&E presentations? Where's you're going to be? Is it certain general practices or certain locations that people are coming from? Is it certain vulnerable groups? One of the things that we did was be able to link population data, which comes from schools. And so most of us that were born, most of us that were born in the 90s would be on a school census register. If you went to a state-maintained schools, we're all tracked basically on these large-scale, national, routinely collected educational databases. And they don't just look at your grades, they also look at how often you're attending school, what your socio-demographic background, something about your socioeconomic status. So they tell us quite a lot about who you are as a person. So if you have that as a population denominator and you link it in with a secondary care data set, you can get the information about who's coming from the population into various services. So what that allowed us to do was be able to say, who is coming into our care? So the blobs on the funnel plot give you an idea of the rates coming from certain schools. So you can discern then what schools seem to have very, very high rates of self-harm presentation to emergency services, something that schools might not really know. So that's quite useful in order to be able to feed back. And on the right-hand side, you can get some gleaning of the characteristics of the type of people that are presenting to emergency services. So this gave us an understanding of just the rates and the increased risk of having an autistic spectrum disorder diagnosis. Gave us some interesting insights in terms of children that didn't speak English as a first language, how they had much, much lower rates of presentation. So is that to do with an awareness issue? Is that to do with they're generally fit and healthier? Or is that to do with some difficulties in recognizing mental health problems in that community? So there's something about being able to use the existing data sets and resources that we have, and just by linking them together, we're able to get a bit more population insights. And the great thing is that you can do this again and again. You don't have to spend millions on cohort studies in your local area. You can actually the data sets exist, just need to link them and refresh that linkage on a routine basis. The second problem, this was another problem that we were interested in, is that ADHD care is really problematic. It's got it's got a prevalence of about 4 to 5% in children and young people. We know that we deliver care for about 1% of that population. So the ways that we were interested in the efficiency, so how do we work out where there are high clusters of need in related to attention deficit difficulties? And one of the things we thought we might look at as one of the clear signals for ADHD is educational difficulties, impairment that sort of occur over primary school. And also there's some interesting features that we might be able to pull out about attendance rates, etc. So using the same sort of data set, what we were interested in was looking at, from the population perspective, who was most likely to get an ADHD diagnosis. And then the idea is that we had some people that were interested in using some machine learning applications to see if we can develop a sort of prediction model that we can then put maybe individually or at a school level to see how many kids within that environment may have ADHD. Again, thinking about resource allocation, could we do better screening and sampling within certain groups or schools? What we found is that ADHD as a diagnosis shouldn't really vary that much by your ethnic status. It should be fairly consistent. When they do population, when they go around the world and they do these big population surveys, they generally find that rates of ADHD are fairly consistent, irrespective of what country you live in. The diagnostic rates are very different. So France doesn't tend to diagnose ADHD much, but if you go to some states in America, you'll find prevalences of about 20%. So it's, but actually, the truth be told, if you go into the population, it's got about 5%. What we found actually is if you look at young people and their social demographic status, we found that we were diagnosing in ethnic minority groups ADHD about half as frequently as we would do white groups. And there is no real argument about why that should be beyond a service delivery argument. So it instantly made us think, well, we can't really run prediction models ultimately because we are really biasing. Because it means if you're Black, you are instantly disadvantaged in your ability to access patient care, because this is going to downplay purely by your ethnic status the risk of you having a disorder. So we then tried a sort of a reweighting model. So this comes back to, again, not trusting the data, going back and talking to people, thinking about actually how would you then adjust potentially for these particular biases that are sort of built into routinely collected data. And so what we did is that on the right-hand side is you've got logistic regression models and some random forest models, which were probably the best predictive models that we had. And then you start to change the weights. And what we found is that you can use some fairness pipelines to actually reduce the impact of things like ethnicity. So you can start to take account of these biases that are inherent within the data that you have. The trouble is, though, is that you can do things with, this is another sort of health warning, really, is that you can do things with these very large data sets, and they're very compelling. The trouble is if you have very, very biased, skewed data sets, that you do run run really into this low prevalence minority imbalance problem. So that does, and I've seen lots of papers that still do this. It's not really embedded yet in the culture yet of clinical informatics, where you'll do models that say the accuracy of these techniques is wonderful. So you've got areas under the curve of 0.86 or whatever. So you're saying this is a great model for going out there and working out who's got ADHD in the population using just education data. The difficulty is that the way that translates down into something that's useful. So clinicians are generally interested in precision. So you can miss quite a few, but the ones that you do get, you want to make sure that they've got it. You don't want to waste huge amounts of time pulling them into assessment clinics, running through batteries of tests to then find that the probability of them having a problem is very low, or you're misclassifying. So when you're reading papers that are based on machine learning, just be, especially where there's real imbalance, do have a look and see if they've provided anything like a precision recall curve, which give you an understanding of actually whether they've really addressed the imbalance of the data. And this is something that we're up against a lot, because most of our conditions across medicine and certainly in psychiatry are common, but they're still low prevalence. They're still very imbalanced, 4-5% prevalences. So this is a health warning for data scientists, is also just be wary of the types of models and the machine learning kind of hype that comes with applying these types of algorithms to routinely collected data. Okay, I'm not doing very well for time, over chatting. So the second thing is, okay, if you've got EHR data that captures everything about patient, that's wonderful. The difficulty is when you go into the records, so you go into these sort of RIO records, or some people have System 1, you've got very, very limited structured information that tells you whether people are getting better or not. We don't tend to, in psychiatry, collect routine outcome measures as much as we should. They're a big part of, they're meant to be part of our culture. They're very helpful for systematically giving you an understanding of someone's needs and difficulties and then tracking that over time. But what really limits us is the fact that we can't really get hold of very good data. And this is a study that we did, which was when you go down and you look at a very simple measure, which is just what's called the strength and difficulties questionnaire. It gives an understanding of conduct difficulties, emotional difficulties, how well kids get on with their peers, etc. You only find a very small proportion of one measure in their system. And then if you want to see what's actually tracked, what's happened over time, it's next to impossible because there is no follow-up collection. So this is a study, a brief audit of our systems, where we found that about, so out of, you had about a third or so actually had one of these measures in the healthcare record. And then if you had one, if you looked 6 months later to see whether progress that young people had got better over time, you had a tiny fraction. And again, we also found that there were biases in the way that these data were recorded. So again, if you're a Black family, you are less likely to have these outcome measures collected. So again, if you're trying to look at systematic improvements within your organization, or whether a particular intervention is started to change your symptom profiles, you're already looking at biased data. So I don't know whether I can, so I can't use the video, but what we did, don't worry, is actually try and think of a digital tool where we can fix this, which very simply, it just automated the survey collection of these outcome measures, with the view that we wanted to try and address this. Thinking about the efficiency argument is that a lot of time was spent sending out paper-based questionnaires, getting on the phone, chasing them up, have you completed them, getting the information back, putting it into the system, and then that information then hopefully then being collated and analysed by the business intelligence team. So what we simply did was just build a kind of like a survey collection tool within our EHR that then nudged people. And just those simple techniques, so just those really simple approaches, have actually dramatically improved our data collection rate, improved for various ethnic groups the data collection as well, because it's just easier to do, and then allowed us some decent analytics. So this gives you an idea, and then to talk to some of the data scientists in terms of the applications, it is helpful to not just think about how you collect data, but how data can be moved around systems that don't operate naturally. So what we found is robotic processing is something we've relied on heavily over the course of a lot of our information flows. I'm going to quickly skip onto these. So what I think is key, beyond trying to persuade people with cash within your organizations to fund these types of infrastructure projects, but it was also trying to build in a sort of a design pipeline. And this is something we find very helpful. So when anyone creates a problem, and this is where you go to your clinical colleagues and you say, what's the issue? What's something is really dragging you down? You need to go through a process of discovery. You then need to go through a process of definition. And then you need to start doing your testing and iterating. Well, I've been involved in lots of groups that have wanted to almost go straight to evaluation or go straight to a solution, want to jump to the end when they don't do that scoping piece of work. So this is the double diamond design framework, which is used as part of our service. So any problem that comes along, we really try and push it through this pipeline and then be able to kind of set our milestones and our project plans based on this process. And co-design is key. So you've got people that are going to be using the end product starting right at the beginning. So I'm going to skip through this because I've not done a great job. In terms of the people that we want, is part of our service, is that we really do need people that come from both from a clinical perspective and also from an engineering and a data science perspective. That's absolutely crucial. So our systems engineering lead knows about back-end development, knows about a little bit about networking, has a DevOps strategy background, and is also very good at understanding the security evaluation. So things like your digital technology assessment criteria. These are all crucial for getting these products situated and then sustained within trust systems. And then I'll leave this up as basically where we're headed. I'm sorry I've rushed those last few slides that are related to innovation, but I'm happy to take as many questions as you're allowed to fire at me. Thanks.
I think Johnny makes that sitting between clinical services and academia sound easy, and it's not. There's lots of different wants and needs and outcomes. It's quite hard when you're short to lean into a microphone. Any questions from anyone?
What ethical assurance tools did you use before you built your model to anticipate adverse impacts of it?
So ethics in terms of the non-representatives of the data or the harms, the potential.
The whole range of, the whole range of stuff to anticipate.
Yeah, so, well, firstly, so just, it depends on the problem, obviously. So let's say we're building in a tool that is reaching out to patients, for example, and then you have a digital divide issue that we have to, and we don't always know how the strength of that digital divide issue will be. We don't know where we're going to be disproportionate. So there's some sense of allowing us to test things and then looking at the scale. One of the things we do as a sort of as hygiene is that we have a kind of we have a patient participatory involvement group that says, we're trying this new technique. What's your appetite? If you received a text message saying, please fill in this questionnaire and also see some signposting services, how's that going to be for you? And we make sure that we have a 50% of our population are from Black and Asian minority ethnic backgrounds. So we make sure that that is represented. It is not just all nice white middle class people who've got some time in their hands that can be part of a PPI group. So there's been quite a lot of effort that have been to do to represent our actual our population. So it very much depends on the problem statement, and the problem statement then draws on some of those sort of inclusive principles, inclusive design principles about bringing in people that would be the end users and saying, does this fit well with you? What information would you need to know in order to feel that it was okay to build the product? And then also, what would you need to see in our testing to make sure that how discrepant we are and what would be palatable? So for the My Health Eve project, we know that we're still getting a 15% misrepresentation or underrepresentation of certain ethnic groups. We know that we also have an underrepresentation amongst those from deprived households. That is better than the 30% underrepresentation that we have using other methods. So there are always going to be biases, but how proportionate they are to the existing systems. And then we can also then say, we'll save time. Can we put more money into phone calls and outreach that can do the same work that the digital tools can't provide? So I hope that gives an illustration of a product.
Okay, we've only got time for one more question.
Oh, sorry.
And your hand was up first.
Well, it's a bit of a follow-up, because thank you for the presentation. It was really good. Of course, you need expertise, clinical trials, mental health, data science, but you seem to be missing ethics, somewhere with the expertise in ethics and AI, because that's my background, philosopher. And I'm concerned because it's growing. People are becoming more and more aware of someone coming from the ethics background. Do you think it's essential in our team to develop a proper ethical product?
Yes, I mean, I'm going to say yes.
It's not there.
Well, I skipped through quite a lot of the innovations work. So firstly, I would just have to quickly say, within ethics, you have to look at what is currently being delivered. And the current system is unethical. So it's all to do with, I would say, the ethical argument is don't kill something because it's just good and it doesn't meet all ethical principles. So these balances, when we're developing research products and projects, obviously they go through an ethics board, and also as part of our project management plan, we always have patient representatives or whoever the user representatives are.
Someone with expertise in ethics in your team?
We don't always have a digital ethicist, and I don't want to get too much into it, but there are sometimes the right time. So, for example, for the speech analytics work, we do have someone with a digital ethicist background, partly to do with if we want to make speech data available for other users to test, what are the ethical ramifications of disclosure when you're looking at speech? And if it's speech about a young person, that needs quite a lot. So a lot of it is to do with the content, not so much of then there's a secondary level, which is saying, if we're creating slightly biased systems, how are we transparent about that? Because every system is going to be biased in one way or another. So those sorts of arguments, I think, they are there. We do have people that have have ethical training in understanding those particular issues and how to articulate them. I'm not desperately convinced that we need an ethicist for every application, because trusts don't have ethics on their business intelligence groups. They don't. They pump out stats. They don't even really check the validation quite often about the information they're drawing on. So I kind of feel like there is room for it, but it shouldn't kill the golden goose, which I think sometimes they do, because they slow things down a little bit. So I'm not decrying your profession by any stretch, but it's just to make sure it's against what are your outcomes that you're up against, and what's the current standard in order to work out what you need, really. Okay, thanks.
I thought that was an excellent answer, because balancing what happens with data in trust with what happens when data scientists and people like us get involved is a real step forward.
Yeah. Yes, it's eye-wateringly different.
And only if you've looked at some of the trust reports would you realise what that was like. So I'm going to hand over now to Marcus Del Pozo Banas to start in the next part of the workshop. So thanks for joining us.
Thank you.